So thank you very much. What I'm going to talk about today is the various challenges in the management of non-muscle invasive bladder cancer. We're going to talk about from the perspective of low and middle income countries like Pakistan and Sri Lanka. Pakistan is a population of over 220 million, with the fifth largest country in the world. And Karachi, where I live, is about 22 million, which is nearly 1/10 of Pakistan. And Pakistan Association of Urological Surgeons, like SLAUS, is a very vibrant organization with nearly 1,000 members with annual and meetings. This is Al Khan University Hospital. This is where I work, and we're very fortunate to have the Center for Innovation in Medical Education with state-of-art facilities in simulators for laparoscopy and for endourology, for training of urologists and further specialties as well. So coming to the focus of non-muscle invasive bladder cancer, it's a difficult disease to treat. Primarily, the reason is that the diagnosis itself is tricky, as there are very few signs and symptoms, and often it is picked up on microscopic hematuria. But then the most difficult part is follow-up and counseling patients about the probable diagnosis, the prognosis. And prognosis, we know, is extremely variable, as you can have a TA low-grade disease to CIS and high-grade carcinoma in situ and high-grade T1 cancer. We know that TURBT is the mainstay for the management of bladder cancer. This is one of the most critical steps in the overall management of bladder cancer, and primarily for the reason that if this step is not properly performed, and if it is something relegated to a junior member in the staff and you're not actively involved, you would regret that decision for the long time to come. So it's important that TUR is appropriately done. You can do it en masse resection, en bloc resection, as is demonstrated in the bottom slide, or you can do piecemeal resection as we have been doing over the years. There's some data now indicating that en bloc resection, if it's feasible, is probably has certain advantages. And these advantages were recently published by our group as well from Al Khan University. And we noted that at least, if not better recurrence-free survival, it is associated with high-quality pathological specimen, which is extremely important in the diagnosis. And also importantly, that the muscle is present in vast majority of specimen if it is done by en bloc resection compared to piecemeal resection. So challenge number one in the management, and this is coming from my own experience over the last 25 years of managing non-muscle invasive bladder cancer, is that the TURBT done is often incomplete. There is missing information about the depth of penetration, which is, as you know, critical, whether it's a lamina propria invasion or it is muscle invasion. It's extremely critical in understanding the exact nature of the disease. TURBT often have missing muscle, and in that situation, sometimes they're even labeled as TA or T1 disease, which is not appropriate. So unless you have muscle and the muscle is not invaded by the cancer, only in that situation it is T1, otherwise it is TX. Another important thing is that the pathologists do not look at in-depth analysis, and they don't really report the variants, and we will talk about the impact of variants in non-muscle invasive bladder cancer and how they should be tackled in the management, subsequent management of NMI BC. So conducted this little survey that I'm going to share with you, two groups of individual, and I presented the same cases to these two groups and achieve a poll and for their opinion about the management. So Group A is a general urologist in a wider national forum in which these cases were presented, and then we collected the poll outcome. And Group B was current residents who are trained in leading centers, who regularly attend webinars, and they're actively involved in the management of bladder cancer. So this is case number 1. And in this case, we presented data about this gentleman, 63-year-old male with a big history of tobacco consumption over 30 pack years. His TURBT was performed, and as you can see on a CT scan, there's a significant burden of disease. His TURBT was performed, which showed a T1 high-grade tumor. However, it was incomplete resection. The muscle was present in the first specimen, and it was not invaded. Subsequent, another TURBT was performed as there was some residual tumor. And even after the second TUR, ultrasound indicated that there is still some residual disease. Now, when we presented this case to the group of general urologists and the specialized trained center residents, the outcome and the answers were very different. So the green is the General Urology National Forum. Majority thought that he should receive intravesical BCG or intravesical, some of them thought even chemotherapy. And very small number suggested that this gentleman should have radical cystectomy. However, if you look at Group B, majority, 45%, either suggested another TUR or radical cystectomy. If you look at the EAU guidelines about incomplete resection, well, you need to have a second TUR, and that's what he had within 2 to 6 weeks. If there is muscle invasive disease or high-grade disease, the patient should really be managed by radical cystectomy rather than some of the more conservative bladder sparing strategies. It's another patient, a 56-year-old male with 20-pack year history, had a TURBT for an isolated 4-centimeter posterior lateral wall tumor, as you can see here. And his top pathology came out to be T1 high-grade in the bladder. There was some suspicious lesion in the prostate, and some chips were taken from the prostate and sent for histopathology. These were mostly hyperemic areas, and what we found that there is urothelial carcinoma, CIS, in the prostatic stroma, and there was stromal invasion. Now, when this case was presented to the two groups, majority of the general urology group indicated that he should have intravesical BCG. Some suggested that he should have intravesical BCG after a deep TUR, whereas 1/3 of the specialized trained center residents suggested that the patient should undergo radical cystoprostatectomy. Now, it's important to understand that patients with extravesical involvement had worse survival than those with bladder CIS alone. And epithelial lining of the prostate, one of the ways of treating this condition, if you want to be conservative, is by deep TUR and doing intravesical installation of BCG, with the hope that this intravesical BCG may spill into the prostatic fossa and may have a local impact. However, if there is involvement of the prostatic ducts and prostatic stroma, this is really a stage T4A cancer. And the only treatment is radical cystoprostatectomy. So important to understand that prostatic epithelial versus prostatic stromal invasion are two very different diseases, and they should be treated differently. Another case, a 67-year-old lady with a history of chewing tobacco. As you may know, that India and Pakistan There's a big population who chew tobacco with the betel nut and betel leaf. She had gross painless hematuria. Complete resection of the anterior and lateral wall of the tumor was done. It was about 6 centimeter tumor. It came out to be a poorly differentiated non-muscle invasive urothelial cancer, which was invading the lamina propria. That makes it T1 disease with micropapillary component. Repeat 2 or 4 weeks showed no residual disease. Biopsies from the muscle indicated no involvement of the muscle. So it was a true T1 high-grade disease with micropapillary pattern. Now, again, opinion from the group A, about 2/3 suggested intravesical BCG, whereas more than 2/3 in the specialized resident group, in the group B, indicated that the patient should undergo a radical cystoprostatectomy. Now, we know that micropapillary urothelial carcinoma and some of the other variants, which include squamoid and glandular differentiation, which include microcystic urothelial, plasmacytoid, giant cell, etc., are mostly highly malignant type of urothelial cancer. And then this distinction of muscle invasion or no muscle invasion becomes secondary, because neither intravesical nor systemic chemotherapy has so far shown any benefit in the management of these patients with the micropapillary or some of the variants that we have. So how we can bridge this gap between those who are trained in good centers and those who are the general pool and they end up doing TURBT, which is run-of-the-mill procedure for majority of the general urologists as well. We thought that tumor board is a good thing, or a multidisciplinary team meeting. We started this about 4.5 years back. And one of the fortunate things that happened in the COVID pandemic, that the physical meeting changed into a webinar. And now it is very well attended from within the city, people who present their cases. And we have a group of urologists, medical oncologists, radiation oncologists, pathologists, nurses, residents, and members of the Karachi chapter of association. And they all give an opinion about the management option, with radiologists reading the thing and pathologists showing. And then we had refresher courses as well to bridge this gap. Most of our residents are now trained on the Vertamad virtual simulator in our university. So their first year training involves doing these procedures on the Vertamad, which provides a near close to life situation in which they learn the technique of transurethral resection of prostate, bladder tumors, HOLAP, etc., before they start assisting in the operating room and actually doing it with their consultants. So it's important that the care of surgical patients, the care of bladder cancer patients, we should need to move out of the silos, working with gaps and a lot of handoffs. So we need to provide that seamless integrated care to our patient. Rather than being transactional, we should be more relationship based. Rather than being passive, we need to be activated, engaged, and empowered. Often the care is facility-centric. However, it should be more patient-centric. Rather than being reactive, we need to be preventive and plan. And rather than doctor becoming the demigod, the decision-making should be based on team approach. And I think MDT meetings or multidisciplinary team meetings are really helpful in this regard. So online access, like the seminar that we are attending right now, and are extremely important in spread of knowledge and information through these platforms, and particularly for our part of the world, where access to these things are difficult and expensive. Little bit about the risk stratification of non-muscle invasive bladder cancer. In 2022, we know that non-muscle invasive bladder cancer is an extremely heterogeneous disease. It has a recurrence and progression, and these are the two problems associated with NMI BC. The recurrence can vary from 30 to 80%, whereas at 5 years, whereas progression can be as low as less than 1% to 45%. So that's a big difference. So you need to identify who's in the 1% category versus who is going to be, there's a 50% chance of somebody progressing the disease from TA to T1 or T1 to T2 or low grade to high grade. The factors that have been studied include the multiplicity of the tumor, the age of the patient, stage, prior recurrence rate, carcinoma in situ, grade, size, and gender, as you all know. And they have been incorporated in the various prognostic tables and nomograms that we have. The first one came the EORTC in 2006, followed by the Kyoto, the Spanish group data in 2009, and then the EORTC again in 2016. More recently, the EAU data, which looked at these parameters. So I'm going to quickly touch upon these various four models in what is new in the 2021 EAU guidelines on risk stratification of non-muscle invasive bladder cancer. So the EORTC 2006 thing was reported by Sylvester in 2006, and there were over 2,500 patients, but only 54% were primary. So they were a bit of an amalgam of patients, and they came from 7 EORTC trial, and the time frame was between 1979 to 1989. Again, the various factors that were looked for recurrence include the multiplicity, size, prior recurrence rate, higher stage, CIS, and grade of the disease. And for progression, the more important factor was the stage, CIS, and the grade of the disease. So from this data, they developed the online tool, which is the Omni Calculator, which was available as a software that you can install into your laptops and into your smartphones. And you can actually classify patient into low, intermediate, and high risk group, and be able to say that how to manage these patients further. This group had mostly intravesical chemo-treated patients, and only 6% had BCG. So the evidence summary from the 2006 EORTC was that the risk table predict the short and long-term risk of disease recurrence and progression in individual using the 1973 WHO classification system. Then came the Kyoto, the Spanish club data from over 1,000 patients, about 2/3 of whom were primary. They came from 4 Kyoto trials between patient managed in 1990 to 1999. So, and significant proportion now, BCG is becoming more of a norm now in the 90s, were treated by BCG. However, the maintenance was short because the maintenance schedule is still not very clear. And majority received 9 to 12 installation, 6 induction, and few maintenance. It basically confirmed the EORTC 2006 model. However, the risk of recurrence and risk of progression were relatively low compared to the 2006 model. And it was basically because significant proportion were treated by BCG in the Kyoto and not in the EORTC 2006. The 2016 EORTC data was reported by Combier and colleague in European Urology in 2016. over 1,800 patients, 55% were primary from TU EORTC trials between 1992 to 2005. And the variables were for recurrence, multiplicity, and prior recurrence, and for progression, stage, and grade according to the 1973 classification. BCG induction is now becoming more of a standard practice when 1 to 3 year maintenance. And minimum maintenance, minimum installations in this group was 15. The comparison with 2009 Kyoto and EORTC showed no CIS in EORTC 2016. So essentially, again, we are looking at quite a variable prognosis in the various trials that have so far been reported. And I think the impact is because of how they've been treated with intravesical chemotherapy and BCG. So now with BCG becoming more of a standard practice, we definitely needed some of the contemporary data to see the impact. And the EAU 2021 report with over 3,400 patients, and all of them were primary. Data coming from 17 centers treated between 1990 and 2018, which was greater than 50% after, and in this, greater than 50% were after 2010. So they are more like in the last 10 years than the older group of patients. So in this, they use both 2004 WHO and 2016 classification system. The grade in the primary non-muscle invasive bladder cancer not prognostic for recurrence. So used for 3 models for recurrence and 4 risk group for progression now for the first time. Previously, we had low, intermediate, and high. And this time we have low, intermediate, high, and a very high risk. And I'm going to tell you why we have a very high risk group patient. The reason why we had very high risk group patient is that in the high risk group, if you look carefully in these tables, and I'm sorry about these busy tables, is that the high risk has significant variation in itself in the subgroup high risk. There is significant variation between 2.4 to 5.2%, and at 5 years between 7.4 to 12. Whereas if you look at the high and very high risk group patients, you see if in the very high risk group patient, the first year disease progression is 16% compared to only 3.5% in the high risk. And it is 9.6 or 10 to 40%, and between 14 and 53% at 10 years. So it's important that these two groups should be separate because of such a huge variation in the disease progression probability. So, and that's why it's important that one should have these two groups. Let's go through some of the cases and to, I think, better understand these 4 prognostic groups. 67-year-old male smoker, isolated bladder tumor on the posterior wall on the left side, very close to the ureteric orifice. He had a lower grade cancer, and if you plot him, now this is the new table which is available for both Android and the iPhones, where you can download it into your cell phones and use it for risk stratification. So age of the patient is important. Now the cutoff between 70 years, and this is something which was there in the Kyoto, but not in the other EORTC tables. Primary versus recurrent, single, multiple, size of the tumor, TA or T1. These are the same that was used previously as well. And if you plot this patient's data, that he is actually less than 70 years of age. This is a primary tumor, and there were more than one. overall about greater than 3 centimeters. Yes. And the stage is T1. There was no concomitant CIS. And if you look at the grade of the disease, it's high grade. So this patient, according to the new table, is high risk with 3.5% probability of progression at 1 year, 9.6%, and 14% at 10 years. So recommendation from the EAU is that the recommendation is that you should use the URTC models. And in this particular patient, BCG is the treatment of choice. The 4 risk categories described by the URTC is low risk, which is primary, single, TA low grade or G1 tumor, less than 3 centimeters without carcinoma in situ, and the patient is less than 70 years of age, right? And if any of these other factors are present, then the patient would move to the second group. High-risk patient is all T1 high-grade patients, except those who are included in the very high-risk group. All carcinoma in situ patient, except those in the very high-risk group. So these are the sub-categorization and their characteristics. If you look at the very high-risk group patient, and I think it's important to understand that TA high-grade CIS with all 3 risk factors, or TA grade 2 and CIS with at least 2 risk factors, or T1 high-grade and CIS at least with 1 risk factors, and so on. So tumor with the carcinoma in situ in the prostatic urethra, and we are talking about prostatic urethral epithelium, patient with a lymphovascular invasion, and tumor with variant histology belong to the very high-risk group patients. Intermediate risk is basically the group of exclusion. So if you are not in any of the other groups, you are actually in the intermediate risk group. So I think I'll skip some of the cases for the sake of time, and basically again, no sooner that you have the data on these patients, you had done a TURBT and the pathology is available, you can plot them into your calculator and treat them accordingly, and you can actually counsel them what are the probability of recurrence and progression. So what about patients who are really very, very unwell and have medical issues? Now, this particular patient who is non-diabetic, hypertensive, ischemic heart disease, had a bypass with valvular heart disease. He's on warfarin, recurrent gross hematuria. He had an MI only 9 weeks back, very poor anesthetic risk. So we only did a flexible cystoscopy, and we found that there was a small low-grade cancer. Now, what you should do, I mean, what you can do essentially is you can't do a TURBT proper to understand, but you have some idea that this is likely to be a low-risk cancer, or at least, or maximum intermediate risk cancer. This is an interesting paper about the use of chemoablation for such groups who cannot be properly staged, but the clinical impression is that of lower intermediate risk group is to use 4 to 6 installation of mitomycin C with a cure rate of about 37%, and this is biopsy proven, or visual clearance rate of over 60%. Patient had relatively good compliance, and the overall recurrence-free survival at 1 year was 84%. So some of these very poor anesthetic risk patients are again good candidates for chemoablation. Are they candidate for active surveillance? And again, something that is very very familiar to the urology community in prostate cancer. Well, there is data that some of these very selected patients can also be treated by active surveillance, and we talk about low and intermediate risk category. And the mean observation over nearly 1.5 years, and you can find that development of muscle invasive disease was only observed in less than 1% of patients. So I think it's a fairly good way for patients who are at high risk of disease. So I think I'm just going to skip some of these cases for the right. What about the role of radical cystectomy for non-muscle invasive bladder cancer? Well, the impression sometimes when you're doing the TUR is that it is likely to be a bad cancer because of the volume of disease. The patient has got sessile growth. There is suspicion of carcinoma in situ and so on. And even though your pathology may not really be representative and does not indicate the same, it is seen that between 1/4 to half the patients are upstaged to muscle invasive tumor at radical cystectomy, who are basically thought to be T1 cancers. Disease progression to muscle invasive disease from those who are at very high risk non-muscle invasive cancer, the overall prognosis is worse than those who were de novo muscle invasive cancer. Well, the risk, if you look at the risk versus benefit in role of radical cystectomy in non-muscle invasive bladder cancer, again, the morbidity and impact of quality of life is a definite problem with radical cystectomy. We also know that these patients are at very high risk of disease progression. So sometimes prudent decision is to go for aggressive treatment like radical cystectomy, and particularly though in those who are BCG unresponsive. It is seen that patients, if the radical cystectomy is delayed in these group of patients, the morbidity and the mortality is quite high. So I'll stop here, and I'm grateful for your attention, and I'll be very happy to answer any question that you may have.